Hi, everyone. This is Rob Packard from Medical Device Academy. Today, we're going to talk about a uFMEA versus a URRA. So these are both risk analysis tools specific to usability or human factors. And in the FDA's newest draft guidance for usability, they mention a URRA, or use-related risk analysis. So, in that use-related risk analysis, how is that different from what most companies are using for usability risk analysis, a uFMEA? And so it's not just the acronym, but the actual content is slightly different. And we're going to explain why. And we're going to even explain how to convert one into the other very quickly. So let's start out with the uFMEA. I'm going to share my screen here. So this is a template for a uFMEA that I created. For those of you that don't know what the acronym means, it's failure, modes, and effects analysis. And they put a little letter usually in front of the FMEA to designate the type. So the most common type is a process FMEA. This is a risk analysis for your manufacturing process. All FMEAs are a bottom-up approach. So you start with what can fail. So you have a list of all your components and you list all the ways they can fail, and then work up to what that's going to cause as an injury or harm or what's going to happen as a result of this failure. And then you look for ways to prevent that failure from occurring or minimize the risk of it. If you have a design failure modes and effects analysis, design FMEA or little d FMEA, you typically take out the column for detectability because it's not a good practice to rely on the detectability of a design error because it's too late. You've already delivered it to the customer. But for process FMEAs, they use this third factor, detectability, because they typically have in-process automated inspection that prevents it from getting to the customer. You've caught it during manufacturing. If you don't catch it during the design process, it's too late. It's already gotten to the customer by the time they detect it. So that's too late. It's not a proactive risk control. So we typically only have the severity of harm and the probability of occurrence of harm for a design FMEA. For a process FMEA, we also add detectability of that failure. For a use FMEA, we have a little U in front, and it's quite different. We still have severity of harm and we have probability of occurrence of the harm, but usually with a usability FMEA, we're looking at hazardous situations, because just because the user makes a mistake, has a use error, doesn't automatically mean that it's going to result in harm. So it usually results in a probability, a probable hazardous situation that always happens in software. The software doesn't jump out and bite you, but the software can create a hazardous situation that could result in harm. So we talk about hazards in hazardous situations for a use FMEA, and for design FMEAs, we talk about actual severity of harm. And so this is what you would typically see on the screen for a use FMEA, and you typically fill it in from left to right. And the way it's typically done is you start with the instruction for use or user manual and go step by step through how the product is used. And you might have multiple use FMEAs for different use cases. So you might create one use FMEA for the normal use of the product, but you might create a separate one for the reprocessing or cleaning and disinfection of the device. You might have another one for service of the device. You might even go so far as to create one for installation or service or maintenance of the device. Nothing wrong with that. That would be excellent if you did those things. But usually where people stop, they like to do the minimum. They will stop with, here's what it says step by step how to use the device. So that's what I've written in the instructions for use. And that's what our use FMEA is based on. The 10 steps to perform the use of our product. Let's say it's taking a temperature with an infrared thermometer, for example. So column B would be each of the tasks that's performed. Column C would be the potential error that a user could make. So you try to brainstorm, how could this user make a mistake? They don't hold it. They hold it so it touches the temple instead of holding it away from the temple by a certain number of centimeters or millimeters. They hold it. They hold down the button, but not for long enough. They hold it down for too long. They don't hold down the button at all. They put in the batteries upside down. There's all kinds of things that a person can do incorrectly. Each one of those has a potential hazard associated with it. A lot of times the device doesn't work, but sometimes it can actually hurt somebody. And if it just doesn't work, that might result in a hazardous situation because you can't treat or diagnose, which is the purpose of a medical device. And then the next item we have on here is potential clinical harm to the patient or the operator of the device. So if you use an infrared thermometer incorrectly, it's very unlikely you're going to hurt the user, but it is possible that you might create a hazardous situation because you incorrectly measure the temperature. So instead of treating them for a fever, you might say, oh, your temperature is normal. But in fact, you just measured the temperature incorrectly. The severity of harm. Well, if my fever is 99 or 100, probably it's just discomfort. But if my fever is 107, it could be a little bit more substantial. So it depends on what the severity of the temperature is, the severity of the misdiagnosis, the severity of the incorrect therapy that I'm going to provide to the patient. So depending on what the situation is, it could result in a different harm, and we generally try to pick the worst case scenario. You could write down both possible scenarios and track them both, but generally we focus on the worst case. And then we have an RPN number. That's usually the product of multiplying the severity of harm by the probability of occurrence. So we have column H is the estimated probability of use error. And you could assume, as the FDA does in their guidance, that will happen 100% of the time, but it seldom does happen 100% of the time. Most people will realize their mistake before they make it, and we'll call it a near miss or a difficulty performing the task, but they'll perform it correctly. Sometimes the device is designed to give us an error message, so we correct ourselves without any harm occurring. So there's a lot of different possible scenarios where it isn't going to be 100% worst case scenario where we're going to have some lesser event that's going to occur, but we prioritize the implementation of our risk controls, or some people will say mitigations, and we'll talk about that shortly. The risk controls will be prioritized based on severity typically, or that RPN number. So I tend to focus on the severity, the things that are most likely to cause death or serious injury. Let's fix those first, prevent those, and then we'll worry about the lower severity items and worry about the probability later. Once we've addressed it as the highest risk items, now let's worry about things that happen frequently. And then the last column is the validation documentation. So making sure the risk controls work. Now, a lot of people will say, well, we put instructions, we put warnings on it, so we don't need to do anything else. That's not how the FDA looks at it. They want you to implement risk controls to prevent those hazardous situations from occurring without relying on the instructions. They ideally want an intuitive device that just you look at it and you know exactly how to work that device. It makes sense in it, and there's some measure of protection from you doing things that are accidentally going to cause harm. But we have to actually validate that it actually works that way. So what do? We do a simulation of use to see if the person in a safe simulation environment will make those mistakes. If it happens frequently, then we need to come up with a better risk control. If it never happens, then we know our risk controls were effective. But we don't have the ability to test everybody in the world. So How many do we test? The FDA says a minimum of 15 users in each user group, which forces you to define who the user groups are. So you might have laypersons, people, any Joe down the street, any Sally down the street, anybody walking into Walmart, CVS, or Walgreens. Those would be your laypersons. The next possibility might be professional healthcare users. So anybody that is a licensed professional that's trained and allowed to use a prescription use device. And then we have specialist users. So an oral surgeon might use devices that are intended for doing oral surgery. A radiologist might use devices that are intended for analyzing or measuring radiology images or taking radiology images. So you have specialist users, professional healthcare users, and then we have laypersons. And you can even segment that further by looking at different demographics like age, education, language, lots of possible ways you can slice and dice the demographics of your user population, but you're required to define who that user population is. So once we've put all this information in here in this table, and we've listed all the tasks, and there will be far more than 2 tasks in most cases, now we look at the FDA guidance and says, oh, we need a URRA, and it's not the same format as this. Well, now what do I do? Well, I'm going to show you, rather than going to the other tab, which is the URRA, I'm just going to paste it in right below. Of course, that's not working for me for some reason. Of course not. Okay, so we're going to have to do it the old-fashioned way. There we go. So now I've copy and pasted what the FDA wants in their 2022 December draft guidance. They say we want a URRA, use-related risk analysis, and they want it in this format. We've seen companies submit slightly different versions of this. The FDA said, no, not acceptable, redo it. When asked, and I've actually asked the head of their human factors group, he said, the reason why we want this particular format is because it takes a lot of time for us to go through every single task and make sure you've done an adequate job of the documentation and the verification of the effectiveness of the risk controls. So we want the absolute minimum amount of information in a traceability matrix so we can go through across each row and make sure you've done everything that needs to be done and no critical tasks were left out. So we don't want it in a different format because then we'll have to learn your format. We don't want more information because then we have to have more information to review than we need. And we don't want less information because then it's incomplete. So we want only what we asked for in exactly the format that is presented here. Well, this doesn't line up exactly with the uFMEA. So if you've done a uFMEA like I've shown on here, and you see what the FDA wants, here's what you do. So the first column is identical. The second column is identical. The third column is almost identical. One says errors with S in parentheses. The other one says error. That's just a heading. So the content is the same. The heading is slightly different. Potential hazards, and clinical harm. So you might have some clinical harm that you have to add. You'll notice in column F of the uFMEA, we have some harms. So you might have some information in F that you need to add to this column. But hopefully D in both of them matches up. You might have a little bit of information from F that you have to manually add. So there might be some manual work there. And if you have a 500-line uFMEA, that could take you quite a while. If you have a 10-line uFMEA, you probably don't have enough use errors identified yet. The next column, severity of harm, that has a severity of harm over here. So what I'm going to do is I'm going to sort of move some things here. I'm just going to copy and, or not copy, but select and move, or attempt to. So cut, paste. So now I moved it over so it lines up. So this column here might need to have information pasted here, but the potential hazardous situation column can be left out. And if the FDA, we've seen a few different versions of the URRA. If the reviewer you're talking with wants that column, they're being different from the draft guidance, but it should be easy for you to add it. Just add the column. The severity of harm column, that matches up. The next test does not match up. This risk mitigation measure is the same as column J. So once again, we're going to select, cut, and paste. So now the old term is risk mitigation measure. The FDA is still using it. The proper term is risk control measure. And so we're saying risk control is implemented in the uFMEA. In 2007, the 14971 standard for risk management eliminated the word mitigation, which means elimination of a risk, and changed it in favor of risk controls, which imply reducing risks. You try to eliminate, but you can't always do it. So we'll use what the FDA has there as a term, and we're not going to argue with them, even though I would love to. But it's risk control. We're going to copy the risk controls down to risk mitigation measures. In the validation documentation, we're going to copy that down as well. So the only thing that really doesn't line up is this section here for, and of course, now it's unreadable. There we go. So the column that's yellow, critical task, doesn't match up with something that's in the uFMEA table. So what you're going to have to do is come up with a rule that says if it's below this score, we're going to say it's a non-critical task. If it's above this score, if it's this score or above, then we're going to say it is a critical task. If you've read what the FDA guidance say, they only want you to consider the severity. So if you have a typical 5-point scale for severity, typically 3s, 4s, and 5s are reportable. Death being a 5, 4 being a permanent serious injury, 3 being a non-permanent serious injury or injury, and 2s being a non-serious injury and definitely not permanent, something that's more of a superficial scrape or cut, something like that, in 1s being no injury at all, cosmetic delay, something like that. And everybody uses slightly different wording and scales, but in general, that's what the FDA is used to. They're used to a 5-point scale similar to what's in 24971, the guidance, and they expect 3s, 4s, and 5s to be critical and 1s and 2s not to be. There are a lot of companies that want to number things 2s so they don't have to be critical tasks. Don't try to fudge your numbers. Instead, count them as critical and do your human factors summative validation. But you will have to do a conversion here. Any RPN, you're not going to worry about. You're just worried about the severity of harm, which is in column G. In the uFMEA, anything that's a 3 or above, you're going to say that's a critical task. Anything that's not. And you could even, if you're doing it in a spreadsheet, have it automatically determine whether it's a yes or no for a critical task. And you could even validate the spreadsheet if you wanted to. So that's how you quickly convert a uFMEA into a URRA. Now, if your uFMEA does not match exactly what I have shown here, you might be missing some data. So before you go about creating your whole entire uFMEA, you might want to take a quick look at that guidance document from the FDA from 2022 in December and see if there's a column that's missing in your template. And then you might want to add that information to your template so it's an easy copy and paste instead of figuring out how you're going to rewrite everything. So we're not saying you can't use a uFMEA. In fact, if you're CE marking a product, you probably will need to have to use that uFMEA because they want more information than the FDA wants. They want a complete usability engineering file, and they want you to include the probability of occurrence. The FDA says, nope, don't include probability of occurrence. How do you resolve the two? This is a case where you can't have one thing makes everybody happy. Your best approach is to make sure all the information that you need in your use-related risk analysis is already in your in your uFMEA, so you can just copy the information over and then create a little formula there to decide whether it's yes or no for critical tasks, and you're done. If you do it that way, it'll be much easier, much quicker, easy to make everybody happy and understood in your company. If you have something that's different for your own uFMEA, or you're using like a fault tree, you're going to have some more work to do. And I'm not beating up on fault trees. Fault trees is probably a better tool for use-related risks, but it doesn't lend itself to what the FDA wants for a traceability matrix. So what you might use a fault tree for your complaint analysis looking at use-related risks might not be what you submit to the FDA in a 510K. So different tools for different purposes, different documentation for different people that you're submitting to. So that's our explanation of how to create a use FMEA and how to create a URRA and how to convert one into the other very quickly, and some few nuances thrown in there and some education on differences between an FMEA and the traceability matrix, explaining what the difference is between use FMEA, design FMEA, process FMEA, and also explaining difference between risk mitigation and risk controls. So I hope you learned those things today. And if you have any other questions or suggestions, please put them in the comments below on this video. And if you found this helpful and you want to share it with one of your other colleagues that's struggling to learn risk analysis or usability engineering, please share this with them, and I hope they found it helpful. Have a great weekend. Bye-bye.